Hello and welcome to the 9th Ifso Journal Club. And for this month, the paper that you have chosen was a systemic review about the effectiveness and safety of Roux-en-Y gastric bypass in the elderly patients. And today we have with us the senior author of the paper, Michael Yannick. Michael comes from the Department of General Oncologic, Metabolic and Thoracic Surgery of the Military Institute of Medicine in Warsaw, Poland. Hello, Michael.
Hello. Thank you for a very kind introduction. And it's a pleasure for me to speak to you about our last research. So I will tell you something about paper titled Effectiveness and Safety of Roux-en-Y gastric bypass in elderly patients. But before I will start describing what we did, I would like to give you an idea why we did our research. So in the picture, you can see an old man who is smiling. And do you know why is he smiling? Because he looks like that. And I bet that majority of you would like to be in his shoes at his age, but the problem is that this type of man is like endangered species. So the majority of old people look completely different. And in fact, when you look at this chart, in 2008 in the United States, around 30% of people who were 65 years or above were diagnosed with obesity. So the problem is that those people come to the bariatric surgeon's office and ask for surgical weight loss. And the surgeon has some concerns about the effectiveness and safety. So that's why our research team decided to investigate if Roux-en-Y gastric bypass has similar safetiness and effectiveness in older people in comparison to the younger ones. That's why we looked for the studies compared Roux-en-Y gastric bypass in patients aged 60 years or above with younger ones. Here you can see the keywords which we use in order to screen those databases. We were interested in overall morbidity, mortality, and weight loss expressed as percentage of excess weight loss. We also look at the secondary outcomes like remission of diabetes, hypertension, obstructive sleep apnea, and length of hospital stay. So in this slide, you can see our inclusion criteria and exclusion criteria. Basically, if we found a report about single outcome of interest, we included the study in our analysis. And here we have a flow chart, and you can follow what we did. So we start with 2,000 records after initial searching, and after removing duplicates, we've got 1,352 records. Then two independent researchers screened the titles and the abstracts and removed about 1,329. So we end up with 23 articles for full text screening. So we screened those texts, and we've got 9 studies which were included into data extraction. So we end up with number which seems to be high, but it's not so high in my opinion, 4,391 patients. But when you see here, only 366 patients were old. So in the table 1, you can see the baseline information of the study. Please, I would like to point out that 3 of the studies included patients who underwent laparoscopic or open gastric bypass. We also assess the quality of the studies using the Newcastle Ottawa quality assessment scales. And now let's take a look at the results here. So first, the morbidity rate. As I told you before, some authors included into analysis in studies patients who underwent open and laparoscopic Roux-en-Y gastric bypass, and others only laparoscopic Roux-en-Y gastric bypass. That's why we divided the studies into two subgroups, and we analyzed those subgroups. When we look at the subgroup analysis, we didn't find any statistically significant difference. But when we look at the overall morbidity rate, and odds ratio is here, you can see the shift into the right, which means that the morbidity rate was significantly higher in the elderly. And the same was for mortality. Look again, here is the shift for the right. So it's not so safe to do this kind of surgery in elderly. And what about the effectiveness? So only 3 studies included the information expressed as percentage of excess weight loss. And when you see at this forest plot, you see the shift for the left. And please take a look here. The mean difference is statistically significant. In general, it means that younger has better results in terms of weight loss. So the excess weight loss, percentage of excess weight loss was higher in younger population in comparison to elderly. And what about diabetes? 4 studies reported this kind of outcome, and when you see at the overall odds ratio for diabetes type 2 remission, again, it favors youngers. So it means that the diabetes mellitus remission rate was significantly higher in younger population, and the same is for hypertension. Again, see the odds ratio here. When we take a look at the obstructive sleep apnea, again, we've got the results showing that the remission of obstructive sleep apnea is higher in younger population. What about length of hospital stay? There is no statistically significant difference. So there is similarity into the groups. So we can reach some conclusions. First, we observed from our systematic review and our meta-analysis that there was a higher morbidity, mortality in elderly. There was less weight loss in elderly, and there was less effect on diabetes, hypertension, obstructive sleep apnea. So we can sum it up in one sentence that elderly risk more and gain less. So there is a question, is it too late for bariatric surgery in this group of patients? This is a good question, and I hope that we can discuss this, but the take-home message is also that it's never too late to do something good for you. So I think we can start the discussion right now. And
Michael,
the floor for questions.
Thank
yes.
you very much for your lovely summary and for your presenting your paper very nicely. I would also like to welcome those Ifso members that are with us at this time, and I would also invite them to send us questions either on this GoWebinar or in there is a question box, or else on Facebook. The paper will also be up for discussion for the next 24 hours on Facebook, as you know. So right now, we currently do not have any questions yet, and I really would encourage the viewers to send some questions. However, let's start by some questions from myself. Currently, what percentage of your patient population would be these people that you would consider elderly, more than 60 years of age?
Okay, so this percentage is not so high, it's around 10%.
10%. And then before you did this study, what was your operation of choice?
Okay, so this is a very good question. So our operation of choice in case of this age group is mainly sleeve gastrectomy. We start with the sleeve gastrectomy. Of course, we check if there is some kind of contra-init reduction. For example, you know, when the patient is complaining about the reflux before surgery, we do not go for sleeve gastrectomy. But for sure, sleeve is the procedure of choice in our case.
And Michael, in my practice, at least here in London, the patients of this age group usually come to see me because they need some joint operations, some hip and knee done, and the orthopedic surgeons usually tell them, no, until you lose weight, we won't do this operation. Although there are other patients that, like your patients, come for diabetes, for sleep apnea. I mean, was there any, when you were looking at these papers, was there any information about that type of resolution of comorbidities, or sort of doing surgery in this group as a bridge to another operation?
Okay, so we didn't look at this, to be honest, and I think this is a very important topic, because you may be right, because of course maybe in this age it is not so important to have, you know, a lot of weight loss, but sometimes I think for these people is more important to improve their quality of life, or to receive, for example, orthopedic surgery for the hip replacement or something like that. So yeah, you're right that I think we need to look at this population a little bit different, in different way, as on the young ones. So I think in future studies we should also take this into the account.
Yeah. Um, I mean, that's why one of my reasons as to how, one of my questions as to how you came out with those outcomes that you chose. Obviously, things like mortality and morbidity at 30 days are very important in any group. But when you were evaluating the papers, were there any other outcomes that the individual papers looked at?
So the problem is that the majority of authors focus on the outcomes which were repeated in every study, and I don't remember well if we found some different kinds of outcomes. The one kind of outcomes which I miss a lot was the quality of life, to be honest. So I don't want to make any, so I don't remember well, but I don't remember any paper from the analysis which reported improvement or any changes in quality of life after surgery in this age population.
Which is obviously quite very important, because, you know, if you're subjecting someone to an operation age 60, they you know, you would need to tell them about quality of life. Now, we've got a few questions on the GoWebinar app.
Yeah.
We've got a question from Anna Komoka from Imperial College in London, and she asks you, in your practice, what is the age limit, if any, for consideration of bariatric surgery? Do you have a cutoff?
Okay, so no, we don't have any cutoff, because I think this is a very individual issue. From our paper, the message is clear. There is a higher risk, and you know, the benefits are low, but still there are some benefits from the bariatric surgery, even for the elderly. But the point is that you need to discuss the topic very detailed with the patient, because the patient needs to be aware of the risk. The problem with bariatric patients is the fact that they are not, they don't accept, they don't want to accept the possibility of complications in many cases. So once you tell the patient that the risk is higher, so some patients decide not to have a surgery. For example, the oldest patient who underwent surgery in our department was 67, and for now it is some kind of cutoff, let's say. Yes, this is the oldest one, and he went surgery well. So
I mean, personally, I have done a few 70-year-olds, but again, like you, I sort of explain, in great detail, risks, benefits, what you would gain from the surgery. And again, MDT needs to be very supportive of the decision. What usually worries me more than anything else is immobility. Are they in a wheelchair? Are they not going to move after surgery? Are they, massively at risk of getting that PE?
Yeah,
That
that's right. And
Yeah.
there is another issue which I think we should discuss, because in the majority of the study, authors report 30 days complication rate and 30 days mortality rate. So, of course, we did the same in our study, and we look in the systematic review for this 30 days period. But lastly, we did a study in our department. We focus on different kinds of operation because we looked at the sleeve gastrectomies, and we found something interesting, because in 30 days period we did not find any fatal cases, but when we extend this period up to 90 days after surgery, so we end up with at least one death which was related to surgery. So I think in this population, it would be wise to look more widely in terms of the period when something could happen.
Let's go for another question. We've got a question from Iyad Wahibi, and he's asking you, did this study change your practice? And if so, how? I think you've already alluded a little bit to it, but if you can, just tell us how it's changed your practice.
Yes, okay, so this study gave me some basics for the preoperative talking with the patients, because now I've got the proof that the risk is higher. So when at the first visit, when I talk with the patient, I explain him that of course the benefits are extraordinary when we are talking about bariatric surgery and are proven, but in your case, when you are above 60, the risk is higher and the benefits are lower. So it's up to you if you take this risk. So I think this is the way how now I'm approaching my patients. Before that, I don't spend so much time in explaining patients possibility of the risk related to the surgery, because we've got this kind of informed consent and the patient could read the consent and we discuss the consent. But now I perform more detailed discussion about the complications which could happen.
Okay, thank you very much. We've got another question from Mohammed Al Fawal, and he's asking for some more details about the actual individual studies. I'm not sure whether you'd be able to tell us these. He's asking about the BP limb, the limb length used in
Okay,
these
this is a
studies.
great question. I will not be able to answer that, unfortunately, but we mentioned that in the limitation section that, of course, we've got a very good study showing that there is a difference in gastric bypass when we are using different BP limbs. And of course, when you look at our meta-analysis and you realize that, for example, when we are assessing weight loss, we got only 3 studies, and in those 3 studies, we could have a different limb length, and this is a limitation. I'm sure about that. That's why I would like to point it out that our meta-analysis and our paper, I think it's important, but it indicates one important thing, that we are short on the data about this issue. We need more studies about that. It's not like that our analysis is very conclusive in the means that bariatric surgery shouldn't be offered to the people who are old. It's not like that. The message is that we've got not so many studies on that, and we should perform more studies. We should think maybe about some confounding factors like BP limb. So yes, the man who is asking about that raised important topic. Thank you for that.
Yeah, and I think I see your point, Michael, what you're saying. We don't only need to standardize the operations, but we also need to standardize our reporting. I mean, you did even comment in your study about sort of different range, different resolutions of diabetes, HbA1c of less than 6, HbA1c of less than 6.5. The blood pressure was, the blood pressure cutoffs, and the percentage excess weight loss, so it's very important, especially when you're doing things like, important things like meta-analysis. Unless you have standardized reporting, it gets very difficult. Mohammed also asked about, what did the paper specify the causes of mortality? What were these people dying of? Leaks, bleeding, PEs? Did they mention anything?
Okay, so to be honest, I do not have data on that. I couldn't answer this question, unfortunately.
Okay,
But
that's fine.
I can tell you something about our material, which I told you before, that we had one fatal case in patients who were over 60. So there was a leak, and in the course of postoperative complications, the person got heart attack. So it was like that.
Yeah, I mean, do you think that the sort of increased mortality rates that you are seeing are just sort of because this group of patients innately in itself has more comorbidity burden? And say if you were to compare them to a group with same comorbidity burden, which were 50 years of age, would they have the same mortality rate, say? Are you just seeing a reflection of the illnesses that
Yeah,
they
yeah,
have, the
I
long-term
know.
illness?
Yeah, I understand. So I think that, of course, yeah, it seems that it is reasonable that there is a connection between the comorbidities and the likelihood of mortality. I agree. The problem is that we've got some case control studies where researchers tried to control those co-founders, and they match the people in respect of the comorbidities, but the numbers of the patients are pretty low, and the majority of those studies did not show any differences in mortality. For example, in our study, not this one, but another one, we did a case match study, and the mortality was without statistical significance. But as I told you before, it's the same study as I told you. When we extended the mortality period, there was one fatal case, but we in that study we had only 65 people, so it's not so much. The study where you've got 60, 100 patients and you are looking into very rare complications are most likely to be underpowered. So I think this is a problem. Now we don't have enough data to answer this question. But of course, I agree with you. It seems that it is reasonable that the presence of comorbidities, it is connected with the higher mortality. Yes, that's right. And also, I think you pointed it out earlier, the functional status. Is the person able to move? I think it's also the important part of the qualification process.
Mohammed also asked us about the definition of elderly, and I gather in your patient you took that as 60 or more, isn't it?
Yeah, this is another good question. Yeah, because there is a debate about that. Of course, World Health Organization defines elderly, the cutoff for elderly, as 65 years old. And we mentioned in the paper that But the reason why we look into the age of 60 is that the majority of papers we checked applied this cutoff. So the definition remains, in my opinion, according to the World Health Organization, is 65, of course. But to be honest, when you see the patient who is 40 and you see the second patient who is 60 and the third who is 65, you can easily see the difference between the first one and the second one, and between the first one and the third one. But you can barely see the difference between the second and the third one.
We've got a very interesting question.
And another, if I can add, sorry,
Yeah.
because when we are speaking about the age and the cutoff, I think there's another important question, because sometimes in our practice we can meet patients who, for example, has 65-year-old, but they function like 45-year-old. So I think maybe we should look more into the biologic age rather than metric age, but we do not have any good tool to assess that.
Yeah, you're right. We've got an interesting question from Ronald Elisoff, and what Ronald asks is that he doesn't think that the question is how do they compare with the younger patients, but what he thinks is important is, are the elderly obese patients better off with surgery or without it? So, I mean, that's where the quality of life questions come in, which is something that unfortunately there's not much data out there to compare. What do you think?
Okay, so this is a very good question, actually. There are some publications indicating that after bariatric surgery, the quality of life improved significantly. I can't recall any a single one publication which investigated this issue in the old population. So if you know anyone, you can remind me. But I agree that this is not only about weight loss. In my opinion, the most important outcome after bariatric surgery is the quality of life improvement, because we do not operate our patients in order to achieve, the highest weight loss. We want to improve their lives. This is our aim. So I think it is still worth to do bariatric surgery in all patients, for example, in order to improve their quality of life, in order to allow them for the orthopedic surgery for hip replacement, as you told before about the bridging procedures. This is my opinion.
Okay. We've got a question from Rodrigo de la Grave, and he first of all agrees with you that sleeve would be a better option in these patients, but he also asks you, do you think that analyzing body composition in these patients is important? And I guess he's getting sort of to think about things like sarcopenia and sort of how not only fat mass loss, but muscle mass affects these patients.
Okay, so he may be right, but I'm not aware of the studies which are assessing this issue in this manner. So it is very hard, to say, because now we can only guessing. Yes, of course, it could be very helpful, because I can imagine that by investigating body composition, we can choose the patient who is, well, let's say, well prepared for the surgery. But I'm not aware, as I told you before, about any single study of that.
I mean, do you think some of these are healthy, elderly, obese patients? Are there any of them that are healthy? And that maybe we should just say, you've lived your life obese, now it's not the time to do bariatric surgery.
Okay, so if they come to your office, there is some kind of reason, yes, that they do that. So I not, I don't believe in healthy obesity, to be honest. I know the concept, but I'm not a believer.
No, neither am I. We've got another question from Iyad, and he asks if you have a 65-year-old with Barrett's esophagus, and so I'm sure that maybe he also has some symptomatic reflux. What would you offer the patient?
Okay, so that time I've got some confusion, of course. I can still offer gastric bypass. To be honest, I like gastric bypass so much. It's a very good operation for surgeon because it's so funny. But of course, to be honest, um, in this case, I would tell my patient that sleep is not a good option for him, and what I can offer instead of sleep is gastric bypass. But of course, again, I would do the talk about the risk and benefits ratio. I think it's not like we should, put away the gastric bypass surgery for elderly. I mean that we should be more carefully in choosing our patient for this kind of surgery, and in general, we should be more, because when you take a look at the research about sleeve gastrectomy in elderly, you will also find some kind of disturbing results about weight loss, if we are talking about weight loss. Because in those papers, a lot of authors reported that the weight loss is lower in old people after sleeve gastrectomy. So if I've got a patient who, in my opinion, because of course we can argue if Barrett esophagus is a contradiction for sleeve, but in my opinion it is. I wouldn't do sleeve gastrectomy in patient who has Barrett esophagus. In this case, I would go for gastric bypass, but it would be up for patient if the patient will accept the risk for the surgery.
Personally, I mean, in my practice, what I would say is yes, I would want to know a little bit more about that Barrett's, whether there is any dysplasia. And, I would probably ask the questions to my gastroenterologist, my GI colleagues as to, what is the prognosis of a 65-year-old having Barrett's? Because yes, we always talk about Barrett's and surgery and that sleep, but what is the chance of this gentleman actually or lady actually developing esophageal adenocarcinoma? And yes, if they say, yes, there is a small chance that in 15 years there's this chance of developing adenocarcinoma. In 15 years' time, that patient will be 80 years old, and at least, here in the UK, there are very, very small numbers of 80-year-olds that would be subjected to an oesophageectomy. And maybe yes, you may want to speak to the patient, offer a sleeve, but also offer Barrett's surveillance, and if there is dysplasia, consider other endoscopic means of dealing with, of ablating that dysplasia, or so I think it's different from would you do a sleeve with a patient who's 20 and has Barrett's with dysplasia. I think it's a sort of different question, and a special age group. I mean, right now we don't have any more questions, so I'll just ask you one of the ones I prepared earlier. Do you think in this age group we need someone to say, listen, we have guidelines for the younger age group. We've got peds and adolescent guidelines. Should we actually have guidelines for the geriatric elderly group?
I think it would be wise to have those kind of guidelines, because from the research we see that this group is different from the younger ones. is different from the other foods. So yes, I agree. I think those guidelines would be very helpful for the surgeon, to make a decision. Because uh, I think, it's very important the reason why the people want to have the surgery. And if we had the guidelines, it would be in general, for surgeon, it would be easier to make the decision, for sure. So I agree. We should have a guidelines on that.
Okay. And just to clarify, none of the bypasses were revisions from things, say, like bands or like sleeves that were included in these studies. These were all primary cases of bypass, were they, in
Okay,
these
so
studies?
uh, yes, it's for me, it's a little bit difficult to answer this question because I'm not aware of single article which we included. I mean, yeah, according to my assistant, yes,
They were primary cases, all
there
primary.
were primary cases. That's right.
Oh, okay. We've got a question from Nazim Hassef, and he's asking, did you find any correlation between BMI and outcome? I.e., was higher BMI related to higher morbidity? So were the older patients bigger?
Uh-huh.
And so do you have a contraindication for operating over elderly?
Okay. So if I understand properly, because we discussing the meta-analysis, so in this case, we do not investigate any kind of correlations. We only analyze the available studies and we discuss the studies, the quality of the evidence and so far. So no, out of the studies, we cannot make any conclusion about the correlation of BMI and mortality or morbidity.
Okay, so they weren't just getting worse results because they were heavier.
Yeah, I mean, we can say that because we didn't check that in this meta-analysis because
Okay.
we would like to, we should do a different study assessing this problem because this meta-analysis will not give us the answer on this question.
Okay. And then what about, I mean, some of the papers that you used were sort of about, 10 years old. And I mean, we know that morbidity and mortality rates and risks of bariatric surgery have decreased over time. I mean, do you think if we were to do a group now and compare sort of the real situation now, would we find such a difference in mortality, you think?
I think we can. Yeah, it is possible. It is possible because we are evolving as a
Mm-hmm.
surgeons. Also, the whole concept of bariatric eras programs. Yeah, I think, of course, and we know that we put a more attention to these specific groups. So yes, I think that if we run studies now, we could achieve better results in terms of mortality and morbidity. But but the truth is that I would like to see the studies concerning on quality of life rather than weight loss. I would like to see the studies concerning more about the functional status after the surgery, because I think it is worth to do the surgery and it's worth to take a risk if we could improve the quality of life and improve the functional status of people who are old.
Thank you very much, Michael. I would also like to remind the viewers and the members that they can ask questions on the GoToWebinar page if they would like. How are you going to take this forward, Michael? Are you doing any other studies yourself, looking into this or looking into different operations and their effect on the elderly?
Yeah, so because we did a bunch of studies and we are finishing this part of our research now. To be honest, the last project which is ongoing now, is to look into extremely old patients, and in order to do that, we cooperate with some institution from US to check in MBS QIP what was the outcome of the bariatric procedures in patients who were over 70 and even 80, because there are some data on that in these large databases. So this will be the last project in elderly, but we did some studies before, and one of the study will be published in Obesity Surgery shortly, and it will be the paper describing the case control study of 65 patients who underwent laparoscopic sleeve gastrectomy. And in this study, we did what you were asking before. We control the comorbidities. So we compare, the patients who had the similar comorbidities like diabetes, hypertension, and we found the results which are very similar to the results out of the meta-analysis. Of course, the number of patients was low, and the study, in my opinion, was a little bit underpowered, but the weight loss was not so good. Again, the mortality was higher. But what I wanted to do in future, I would like to look more into the quality of life after bariatric surgery in this age population.
Thank you very much, Michael. We don't have any more questions. It has been a splendid journal club. Thank you very much, and good luck with this. We look forward to read your paper, and thank you very much for being with us today. I'd also like to thank the attendees. I would like to remind you all that the next journal club will be on the 18th of April, and this time we're going to discuss a paper published in The Lancet, and it is the efficacy and safety of one anastomosis gastric bypass versus Roux-en-Y gastric bypass for obesity, and that's the Omega study by Maud Robert. That's going to be on the 18th of April, same time as usual. And so we look forward to joining you then. And I would also really like to thank the woman who's, although she's not being seen, she is behind this all, and that's Manuela. She's keeping us all in check. So thank you very much, Manuela, for sorting out all this. Thank you, Michael. And I look forward to seeing you soon. Hopefully to see you all and meet you all in person in Madrid in Ifso 2019. Bye-bye.
Bye-bye. Thank you so much.
Bye.